thank you, Dean Porrick, for inviting me to talk about concussion, a subject that I have an interest in for a long time. And I'd like to share some ideas with you, and thank you for coming. It's a large number of people for a topic of interest to everybody. It's not just sport people, by the way. Concussion is something that can happen to you any time in your life. I wonder, I'd say many people here have suffered one episode of concussion, and certainly if you play sport, it's probably more than one episode. Possibly should have waited for a while, so if anybody was asleep, that might bring them around. But that's just the background. The situation is this: in rugby, you have to tackle with your arms, so you can't charge. Spear tackles, dropping somebody on their heads, or tackling in the air, or charging into rucks. All of that has changed since that video was made. So things have improved, but the game is faster in rugby, and I'm talking mainly about rugby here because I have all the information. As the players get bigger and the contacts get bigger, the risks are greater. And the thing to remember about the contact, it doesn't have to be your head to give you a concussion. Any part of the body you can carry, the impetus is carried, the impulse is carried, and it can shake your brain. And really, concussion is about shaking your brain. So if you shake your brain, you can get concussion. And the question for all of us is, if you do it frequently, are you at risk of long-term consequences? And at this moment in time, we don't know the answer to that, but we have fears and worries about the future in that area. So I'm just going to show you another one, hopefully.
A concussion is a type of traumatic brain injury, or TBI, caused by a bump, blow, or jolt to the head, or by a hit to the body that causes your head and brain to move rapidly back and forth. This sudden movement can literally cause the brain to bounce around or twist in the skull, stretching and damaging the brain cells and creating chemical changes in the brain. What you might not know is that these chemical changes make the brain more sensitive to any increased stress or injury until it fully recovers.
So I think that's pretty descriptive of what happens when your brain is shaken in the skull. The skull is a rigid, solid object, a solid, bony, and you've got your jelly. Your brain's like a jelly, so it's pushed around. Thanks. And if you get hit from the side rather than head on, it rotates your brain, which causes greater risk. So in boxers, when you get a punch in the jaw that turns your head suddenly, it'll knock you out faster than if you get a direct blow to your head. So anything that forces the brain, soft brainy tissue, against the skull, which is hard, solid tissue, will damage your brain. The question is, how much damage do you get with concussion? and what are the long-term consequences. So this has been looked at for some time. I was involved with one group in 2008, and there's been a subsequent group looking at concussion, a consensus statement, an agreed assessment and protocol for concussion, where all the best experts in the world were available and advising, and then this consensus statement was arrived at with advice for everybody, from the average individual looking after themselves to parents to school teachers to coaches and so on. So it's everybody needs to be actually educated in concussion. And the more recent was the 4th International Conference in Zurich 2012, and there's another one up in 2 years' time. So the consensus statement, as I said, is based on a factual document which and it's updated every 4 years, and it's basically, the process is borrowed from the NIH in America as a consensus statement, and it's developed for therapists, certified athletic trainers. This is a very Americanized side to it. For all health professionals, coaches, trainers, so everybody has to be aware. And all the sporting bodies here, and more recently the ERC, the subcommittee, have issued a statement on concussion. So everybody needs to be educated to deal with it. So I'll answer now the biggest question that most people in my situation are asked is, what's the most important bit of information for somebody who's not medically trained? And the most important thing for any one of us, trained medically or not, is to get the individual off if you see them, if you see a collision, and if you think they're concussed. Because as we go through this discussion, you'll find that it's very difficult to make a decision in the middle of a game, particularly at professional sport, but at any level, the correct decision is very difficult to come to. For the professional game, there are video analysts on the touchline advising the doctor using a computer or a mobile phone about the severity of the collision. If the medical officer, the doctor, the medical professional doesn't see the injury, but it's critical to see the injury, and when you see the injury, then you should be making up your mind, because it's very difficult in the heat of battle to make the right decision. Is always take them off, by the way, but sometimes that gets lost in the heat of battle. So it's the definition, the accepted definition of concussion has been changed a few times, defined as a complex pathophysiological process affecting the brain induced by traumatic biomechanical forces. And then it includes clinical, pathological, and biomechanical injury. So it's a biomechanical injury, but then it has a pathological component to it. And so it can be direct blow to the head or face, or it can be an impulsive force. So you get somebody tackled, and there were examples over there where they were hit on the legs, and that was enough to shake the brain. And we're all different. We respond differently. Children respond very poorly to head injuries. And there's this rapid onset, a short-lived onset of impairment of neurological function, and we'll come to the various symptoms in a moment. These normally don't cause you any damage to your brain, we think, because we have no way of measuring it accurately, but there are new modalities now that will make it a little easier. And so loss of consciousness can occur, but it doesn't have to be a loss of consciousness. And in fact, loss of consciousness isn't singularly the most important thing. But you don't wait for somebody to be knocked unconscious, is the message I'm trying to get across. That's serious, and it's easy. Somebody's out cold, you have to deal with that. You may well have to resuscitate them. And in the context of a contact sport like rugby, you have to be very aware of the fact that in that context, they may have injured their necks as well. So you have an unconscious patient with a neck injury, possibly neck fracture, certainly catastrophic injury is described as. So you have to be careful, and therefore they have to be treated all as if they have neck injury as well. So if most of them get better, and say 80% of them are thought to be better by 7 to 8 days, sometimes in 1 day, but usually there are some more residual but less dramatic symptoms in the interim. And if you x-ray them in the normal x-ray or MRI scan, CAT scan, you don't see anything. But there are newer machines out there now that will hopefully give us more insight. So it can either be a headache, feeling like in a fog, which is a very often description, or just what's called tunnel vision. Individuals can only see straight ahead, they can't focus on the wider picture. There's an emotional symptom, they behave strangely. And then the physical signs, if they're unconscious, or amnesia, then the irritability, they're very upset or agitated and so on. This can be on the pitch or off the pitch. And then the reaction times are slowed. And that is the thing that's mentioned there in the introduction of the shaking of the brain. If your reaction times are slow, you definitely shouldn't remain on the pitch, because we know from experience that second impact is always more severe. In other words, you're not fully aware of your surroundings, not able to deal with the next impact, and so you get more seriously injured. So it's critical to get everybody off. And then they get sleepy and drowsy as well. So if somebody is concussed, no matter where, if it's a child, they won't be drinking, but they shouldn't drink or drive afterwards. They should be taken home and observed for at least 24 hours. If you go to any accident emergency department, they give you a little leaflet about that. So any of these components, you then have to work out your strategy. And the strategy, as I said again, and every time is the same. Do not leave anybody on playing any sport if you suspect concussion. The diagnosis is not as easy as you might think, but if you suspect, to take them off and then evaluate them at the sideline. So if somebody is on the pitch unconscious, you have to think they've got a neck injury as well. And that can happen at any level at any sport. So you have to treat them as if they've got a cervical injury, and therefore you do need in advance to have the right equipment with you, if it's a big competition, or any competition probably, and have collars and stretchers and so on, and people trained to make a decision. So the healthcare person on the spot, the individual on the spot, it mightn't be somebody trained in medicine, it could be the coach, a parent, and I'm sure you've all had experiences, frightening experiences like that where you were the only person available. We should all have basic knowledge and know how to manage this. If the patient's unconscious, that's a major challenge. If they're not unconscious and there's any doubt, keep them off the pitch. So taking them off safely if there's any serious injury. And then on the touchline or in the medical room, whatever you've got available, you can test them out on this SCAT scan. This SCAT is a questionnaire, which is standardized worldwide acceptable questionnaire, or similar tool. There's a Maddox questions, there are 3 or 4 of them, but they're not easy to do, folks. And if you don't practice them in advance, you will not get it done in 5 or 10 minutes. It is difficult to do, and unfortunately, some players in professional sport learn them off in advance so that if they're asked the questions, they foolishly, bravado comes into it. They think that's great to go back on again because you're a hero. Unfortunately, this happens all too often. So afterwards, they shouldn't be left alone. They need to be monitored, and they mustn't drink or drive. So there needs to be somebody with them. In professional sport, there is somebody there. There's a nurse or a doctor with them. And the other thing, of course, is that when they come off the pitch, they need to be carefully evaluated. The questionnaires have to be dealt with, and then the decision has to be taken whether they go to hospital or not. Is this a serious one? Is this somebody somebody who may have a fracture or bleeding? And it's very difficult to make that decision. If it's serious and you're worried, you have to send them to hospital. If you don't have a trained person there, you definitely just send them along to hospital to be checked out. Because particularly with children, they respond poorly. They get brain swelling rapidly, and they actually deteriorate very rapidly. So they're a big worry, children, much more than an adult. So you need to have the facilities available as well. So if you're responsible for a club or an organization, it's not enough to turn up yourself. You need to have facilities there, a place to park an ambulance so the ambulance can get in, and some basic equipment. But there should always be somebody trained in first aid. In my opinion, no competition involving contact sport should go ahead without a first aider. There should be a first aider there. In fact, I played rugby in England some years ago, and even then the referee wouldn't start the game, an amateur game by the way, without a first aider. There were 4 medics on our team, but that didn't make any difference. They wouldn't accept them, as rightly so, I think, in the circumstance. They'd have to be first aiders. So you need to have somebody there to assess them accurately. And these questions, the Maddox questions, this concussion, SCAT, or abbreviated version, they're all very useful, and they should be available. And they are available. You can get them. All the sporting bodies in Ireland have those available for clubs and so on. The neurophysiological, psychological questions are very rarely done in Ireland because we don't have many neuropsychologists. You have to be in a special centre to have a neuropsychologist. But in American football or ice hockey, where it's professional sport, predominantly professional sport, they're part of there's always one of them there, and they go through it in great detail. Don't forget that you may be fine for an hour, deteriorate suddenly, get sick suddenly. So it's very important to continue to monitor. So in the ideal situation, you're now in a medical room with the GP or in a hospital outpatients, accident emergency department, and all these things can be examined by people who are reasonably experienced. And then you have to get more information from the coach, from the parent, from the teacher, whoever's there, whoever observed it. If you don't have a CT scan, if you don't have a video of it, like you will have in the professional sport. And then the next thing is, do you send them for a brain scan or a CT scan or an MRI scan? So that's very important. And just to mention that the SCAT-3, that assessment, is a concussion assessment tool. It's a tool for assessing all those symptoms and signs that we mentioned earlier. This is part of the consensus statement. This is regarded as the absolute must. And it's absolutely repeated while they recover over the next period of time, depending on how quickly they recover. There are new modalities now. There are these perfusion and diffusion scans you can do. They're very detailed. There's a lot of radiation involved, so they're not standard. But the newest piece of equipment that's used and available, but not readily available, I hasten to add, is the functional MRI scanner that'll check the brain function after a concussion. And there are changes on those scanners. You can see some changes in the brain. So these are frequently seen in the frontal lobes, which are behavioral lobes in the brain. So it fits into the clinical concepts that we were talking about earlier. And then, they're monitored after that. The PET scan is not usually used in this situation because it's got a huge amount of radiation involved, but occasionally studies have been done with it, and it is not probably, and I hope there are many radiologists here, but I'm informed it probably is not something that you can repeat too often because of the radiation. So this is objective balance assessment, and there's on the SCAT, and this questionnaire, you can try balancing. You notice a lot of players after they're concussed, they fall over, obviously after a contact, aren't steady on their feet. And this can go on for 72 hours. And so concussion management then is assessment and follow-up. The follow-up is very critical for everybody. And I've got down here graded exertion, medical clearance. You can't, according to the rules of the International Rugby Board, for rugby, you can't go back to play again or train again until you're cleared by a doctor. That doesn't happen, of course, very often, but in the professional sport it does. And then there's a return to play protocol. So if you see a professional player injured on a Saturday and they play a week later, that's because they've gone through this graded return to play. They've gone through a detailed return to play, which takes up a lot of time and so on. And the one thing that everybody agrees on, you must not return to play the same day. So in some years, the worries about concussion arose in American football some years ago when the New York Times reported retired NFL players, American football players, with brain damage following death. They died early, they donated their brains for medical research. We'll come to it later, but the Congress in America have control over football, and because nothing was happening to the rules and regulations, they brought in a law that stated if you were concussed playing American football, you had to come off and you could not go back to train or play again without being assessed by another doctor, not the team doctor. So it had to be another individual. And this is the graduated return to play, where there's no activity, complete rest. And for children, that means not playing with their computers and not going to school to rest their brains. Difficult thing to get kids to do. Then the next stage, and that's a day, if they pass that day one, they go on to day two. Light aerobic exercise, walking, swimming or cycling, no resistance training, and you have to do enough exercise to increase your pulse rate from whatever your static race is. Then the sport-specific exercise like running drills or no head impact obviously, and added movement. In other words, increasing it all the time. And if you pass through that without any symptoms, then you go into non-contact training drills and gradually increase the load over the next few days. And if everything is fine by the day six, you can go back to train and play. So that's the program, and that's what gets people back very quickly. And there's always a question mark whether they should be back or not. But there are players who are kept off now for months until their symptoms go away. There are people who have symptoms for the rest of their lives following concussion, and that is the worry that we have in every single case. And that is so important to go through this process and make sure they're fine. Then there are lots of modifying factors because we're all different and people have underlying diseases and they're on medications and so on. And this can predict the long-term outcome. Like for instance, people with migraine when they get concussion frequently get recurrent attacks of migraine. Every time they get head contact or they shake their heads, they get a migrainous attack. That's another problem that needs to be dealt with separately. And then, just get a list of them here. The concussion modifiers. So this is the information that the clinician needs to have making a decision for any individual person, whether you're a professional or an amateur, your child or adult. The duration of the symptoms, so you've been monitored greater than 10 days, is significant. Severity, obviously, more than one symptom that lasts, headache, drowsiness, nausea, etc. Concussive convulsions or prolonged loss of consciousness, more than 1 minute loss of consciousness. Always difficult to measure, but easy when you've got a video machine to look at. You can count it, but always difficult in a contact sport, in any sport. And then the frequency, repeated concussions over time, and the interval between them is important. If they're very close together, then that's cumulative and that's more worrying. And in some people who've had a previous history of traumatic brain injury, and this is one of the confounders for all of us, is traumatic brain injury is a little more than concussion, where you can actually find some evidence of brain damage. Not serious, that may leave you disabled long term, but enough that's found on these investigations we're talking about, the MRI scans, the CAT scans, or the clinical evaluation, the testing, the neuropsychological testing. So if they slow recovery between concussion, that's another reason to delay the return to play and so on. Children are a particular worry because they are high risk of serious injury from fairly trivial head contact. They can actually get brain swelling and be at risk, immediate risk of long-term damage, and death in some cases. And the comorbidities, I mentioned the migraine, but depression is one that you've seen a lot recently. Ex-players are now talking about how depressed they were when they stopped playing, and how depressed they were, sometimes after these kind of injuries. And that's a well-known feature. And if you look at the functional MRI scanner, you can see the changes in the lobes in the brain where relating to this area. Then if people are on drugs, psychoactive drugs, any kind of drug, but certainly you shouldn't be playing contact sport if you're an anticoagulant, because you bleed if you get it. Any contact causes you to bleed, but they're contraindications. Then behavior, dangerous style of play, and we saw plenty of examples of it there on the video. And then high-risk activity. I don't know whether climbing Kilimanjaro Pori comes under that or not, but high-risk activities, contact, or cage fighting and that kind of stuff, the risks increase. So the significance of amnesia is always one that's always been a big query about, but the evidence suggests that it's not the most important feature of concussion. There are other features more important. And then depression, back to it again. And this MRI scan shows the limbic frontal model of depression on the MRI scan. The MRI scan will tell you if there's been some kind of disturbance. Not that you need to know it if you get a bang on the head, because when you saw the original brain shaking around there, it's bound to do some damage, but usually it's not significant. The MRI scan will pick up even the mildest amount of damage. And obviously, if you have something on an MRI scanner, you can't go back to do anything again until you're cleared on the MRI scan, and you're cleared by experts as well. And then there's this question, chronic does it cause dementia? And there's been some evidence to show that repetitive head injuries and dementia have been, people have had early dementia, and that excludes the family history of dementia. So can you protect somebody if you wear a mouth guard or a helmet? Mouth guards certainly protect your teeth, but they do not protect you from concussion. They certainly save your incisors. Helmets have been used in every shape or size or form, and they have no benefit when it comes to concussion. They protect you from a fracture or from a cut. And in rugby players, that they wear these to save their ears so they won't look ugly later in life, look pretty, and to prevent cuts, but they don't protect them from anything else. But the American helmets of football probably protect them from a fracture. In soccer, there was a problem in soccer some years ago where there was, when the ball was in the air, your defender probably used his elbow on his opponent in the head. Well, they stopped it in soccer by giving a red card every time that happens. And if we look at other sports, there's a lesson to be learned there. Rule enforcement. So then it's a knowledge transfer. It's a phrase that's used now for information. Athletes, colleges, colleagues, and general public, referees, administrators, healthcare advisors. There are programs in all our programs in sports medicine. There's a module on concussion, and you've got the website-based educational videos, outreach clinics, and so on, and all the major sporting bodies who contributed to the consensus document every year. They all have this information readily available. So in ice hockey, if you look at ice hockey, where it's from the age of 7 or 8, like if you don't take it up early, you'll never learn how to play it. They have very special arrangements for children. They're very strict and very accurate, and they cannot play unless there are experts on the sideline, and there are representatives from their families' parents there as well. They're very strict. So what do we do in the future? You validate the SCAT, and there's a special one for children now as a thing from adults. So that's the move in between every 4 years. Paradigms for pediatric injury and management, and I think there's a need, there's need for us to actually have some data on injuries in children in sport and otherwise. We don't have it in Ireland, but I think it's about to start. The gender effects of injuries. Women are more likely to have recurrent problems with concussion than men, and that's not been proved with large studies, but there's a feeling that that is the case. Then virtual reality tools to measure injury, rehabilitation strategies, exercise programs, the functional MRI scanner, and then doing studies on individuals and following them through for years afterwards, or going back and looking at players in every sport who were injured 20, 25 years ago and doing a functional MRI scan on them, if they volunteer for it, by the way. It's all voluntary. And then, looking at the future and looking at other ways of best practice in managing these patients. I'm talking now about after they're off the pitch and they're recovering. And the long-term outcomes are very important, and we're unsure about them, except in American football there's some question about this chronic traumatic encephalopathy. So one has to remember that if any one of us organise a sporting event, we need to be responsible for any outcome. So when you're taking on the running of something, or you're the person with the responsibility for concussion or anything, you have a major responsibility to make sure that you can handle the situation, and that depends very much on your level of expertise. But what we're saying is there should be more people with that kind of information available all the time. So the document, the consensus statement, is written it's not a medical document. It's written so that it can be understood by anybody. And this intent, improving the standard of care, improving the knowledge, but using the document, because the document is only a guide. It isn't an absolute factual document. It's a guide to how you might manage concussion with or without a lot of medical knowledge. And each case will be different and will need specific kind of treatment. And this document is being reviewed again. It's been reviewed, in fact, in 2 years' time. So this involves all those people here, medics, other medical personnel, coaches, trainers. In some countries, coaches and trainers are not allowed to coach or train until they have first aid certificate, and they're recertified every 2 years. And I think that is very important, particularly in amateur sport, and especially so with children. So parents and teachers need to know how to manage these situations as well. And if they use the SCAT document, that will help. But there should perhaps be some coaching, some help in sporting organisations. So I mentioned earlier that for professional sport you have the video analyst who informs the doctor on the spot that he's worried about a particular player. Then they're removed from the field of play, and they're evaluated very carefully, and the decision about whether to send them to hospital or not. They mustn't go back to play that day. Very rarely should anybody ever coming off the ground with suspected concussion ever go back. I would say they should never go back. And they must be observed carefully, and then the protocol comes into it in the final medical clearance. Okay. So just concussion itself, we're back to it again, and this is contra-coup effect, where the brain is shook around the head. There's no doubt that it does stretch these very sensitive nerve fibers in the brain. There's no doubt about that, which could result in some or minor injury, or could give you more severe injury. So there's certainly transient neurological dysfunction during acute attack. It's very common, and some of us feel that rather than having concussion used in the future, every case of concussion should be called mild traumatic brain injury, because that has much greater resonance with all of us. Whereas concussion, people don't take it seriously because their grannies and their daddies and so on had them before and they're fine still. I think if we agreed on that the next time around for the consensus statement, that will increase awareness and observation. We don't know how many occur, but this is an estimate between 1.6 and 3.8 million annually in sport. It's an underestimate. And in football, estimate is that 80% never seek medical advice. Soccer, that is. So this is the worst case scenario where these players in America, and I think we must remember this, just remind ourselves to take it seriously and to try and prevent the injury first of all, but also make sure that we maximize the management. 35 brains of deceased athletes. Now many of these athletes donated their brains before they died, and many of them committed suicide, but their brains were intact. 13 brains, and this was in a central medical school in Boston. Controversial and not proven beyond all doubt, but still a very worrying picture. There were 13 brains of former NFL players. 12 of them had chronic traumatic encephalopathy. This is irreversible brain damage with a very classical pattern of brain damage on pathological examination. And 3 of them had motor neuron disease as well. And they call that chronic traumatic encephalomyelopathy. So that was the American picture. The rest of the world haven't been reporting those cases, though there have been isolated cases. But everybody's now looking at these brains and looking at preventing this happening. I mentioned the helmets earlier. They don't help. They help fracture. They don't help for concussion. And therefore, they give a false sense of security. So somebody wearing a helmet or a scrum cap, they have a false sense of safety. In fact, they're at risk. It's a false sense of safety. Because of this problem in America, this Sports Legacy Institute was set up, and they have a 10-point plan for safer sports. That's close every sport. The game has to be reevaluated, and that applies to all contact sports where these injuries are occurring. And then education being mandatory, which I mentioned earlier. You have to have everybody, there's got to be somebody there for every competition where there's contact, risk of head contact or body contact that causes a concussion, to deal with the problem. That includes everybody, parents, coaches, athletes. Looking at protective equipment, that's been re-looked at again, and they've produced, modern day helmets which have been looked at in laboratory models. And they can measure the contact forces like we can in every sport. You can actually measure contact forces in rugby by wearing sensors, and you can wear, some rugby team players now wear them at the back of their ear there, and measure the force, the contact force as it affects the brain. Management and diagnosis must improve, but the management in particular, and the management again, I'll go back and say that you get them away from the game, get them away from contact, get them evaluated, and if you don't know how to manage, get somebody else to do it. Looking at techniques of play, and in rugby there have been lots of changes, the high tackles and so on, the referees have been tough on that, and that goes without saying, that's absolutely needed in every sport. The rules need to change to minimize head contact, to avoid head contact. And referees have to be tougher, and then finally, probably the toughest one of all is the culture of the game. People accept a lot in sport, but then if we look at professional sport, it's an occupation. It's occupational injury you're looking at, and that makes it completely different, even though it doesn't always get applied to sport. So basically, for concussion, and I've gone through it, hopefully you've learned something from it, but the message very simply is that we're taking it seriously now. We've always taken it seriously, but we have better ways of measuring it, and for some years we've been looking at a clinic with all the expertise available, and we have one now which will be open shortly at St. James's Hospital in Dublin, where they have a functional MRI scanner, and they also have neuropsychologists. They have the full list of experts to do a complete evaluation on an individual with concussion, referred there by a doctor having been diagnosed with concussion. And by scanning them with this functional MRI scan and doing all the other measurements, we're in a position to know whether there's been any immediate changes or not, and then you repeat the scan again after a period of time to make sure that nothing has appeared in the interim. And I think by doing that, it's the safest way to learn about concussion and to deal with the more severe cases. But it will continue to happen, and we all have responsibility. And the emphasis from parents to trainers to coaches with the medical profession really have a big responsibility here. We are looking at it, and also in Trinity College they've got an animal model of concussion, which will be looked at as well. In other words, you can simulate the injury in an animal model and learn from that. This work is ongoing at the moment. So that's the way forward. But in the meantime, we have to all take take this responsibly and make sure that we protect our youngsters in particular, and all sportsmen. And don't forget, these injuries occur in everyday life too, so we should know how to manage them. We certainly should all have a look at the SCATs, and it's easy enough to remember it, to read it and understand it, but it does take time to go through it in detail if you're the individual making the decision. And if you have any worries, pass them on to the next person, to the GP, or send the individual to accident emergency departments. Thank you very much for listening. I think the most important thing for anybody involved with concussion, a spectator that is to take the individual they suspect for having concussion off the pitch, away from the further danger immediately. That's the biggest message and the absolute necessity, in my opinion.
Yeah, it was fascinating to hear from Professor Molloy, considering his background in Irish rugby, and also he's kind of at the forefront of concussion in Ireland at the moment. It was great to further understand concussion. I think I had a very basic understanding of it beforehand. Certainly elements of multiple different sports that were mentioned was another fascinating concept, because I know rugby is one of the ones at the forefront of Irish sport at the moment, but the changes in the football laws, that's soccer, and American football, there's a lot of talking in recent times, since I think 2008, with the brain traumas associated with ex-players.